Good afternoon, everybody. I'm delighted to invite you to the first of our ESID grand rounds. And today we're going to be talking about managing COVID in adults with antibody deficiency. And if I can have my panel members and speakers on screen with me now, I'll introduce everybody. Great, thank you. So I'm delighted to introduce Adrian Shields, who's going to be presenting the main case we're going to discuss today. And Adrian's from the University of Birmingham. David Lowe, who's my colleague here at the Royal Free and UCL in London. Klaus Warnatz, who we all know well from the Department of Rheumatology and Immunology in Freiburg. And Charlotte Cunningham Rundles from the Icahn School of Medicine in Mount Sinai. So David, Klaus and Charlotte are going to be our esteemed panel. We will have time at the end for Q&As. If I could have the next slide, please. Just a couple of Zoom tools and tips. If you want to ask us a question, put it in the Q&A at the bottom of your screen. The chat will not be used for this function, but if you have any technical issues, you can put them in the chat. So I think without further ado, in the interest of time, we shall start and I'll hand over to Adrian to begin with our case. I hope you all enjoy it, and please do fill in the feedback afterwards.
Thank you very much, Siobhan. So I'm going to present a case which is from Birmingham and will highlight some of the challenges of managing COVID-19 in a patient with antibody deficiency. Should we have the next slide? So this is the characteristics of the pandemic in the UK, and if we just flash up the next part, the events with respect to this case occurred between mid-February and the present time. Next slide. And again. So the case concerns a 30-year-old female. If we go back one slide, who first presented at the age of 18 with a hypermobility syndrome and the possible inflammatory arthropathy. She was rheumatoid factor positive and had some evidence of inflammation on her blood tests. And at that point, she was treated with physiotherapy and sulfasalazine. Her calculated globulins at the age of 18 were 21, which I think are borderline. And at the age of 20, she was diagnosed with autoimmune hepatitis, which was biopsy consistent with autoimmune hepatitis, but serologically negative. She was treated with some prednisolone, and azathioprine was initiated. And shortly after that, at the age of 21, rituximab was started. Next slide. She was referred to the immunology service in 2017 because of increasing respiratory tract infections over the previous 3 years. And at the point of referral, she was found to be hypogammaglobulinemic. She was a healthcare professional, and looking back at her results, she had failed to mount a response to hepatitis B vaccination prior to rituximab being given. Her cellular immunology showed a minimal population of B cells consistent with previous rituximab treatment. The rest of her cellular immunology was normal. She had no pneumonias at the time, no hospital admissions for infections. So if we move to the next slide. She was treated with some azithromycin prophylaxis with a low threshold for initiating immunoglobulin replacement if infections progressed, and a diagnosis of likely common variable immune deficiency was made. Over the course of the next 3 years of follow-up, her immunoglobulin slowly trended down, reaching 3.35 grams per litre in December of last year. And she was shielding at home during the COVID pandemic, the first and the second wave in the UK. Next slide. So our case really begins in mid-February 2021, where the patient's partner, who was also a healthcare worker, tested positive for mild symptomatic SARS-CoV-2 infection. At that point, the patient had a positive test on the same day as her partner through community testing, but was asymptomatic. Next slide. So we have some audience participation questions. The first question should be coming up on your poll right now. And the question is, what would you do with the patient at this point in time? We'll give 30 seconds more to vote. I can't see the results, but I'm hoping some results have come in. So the majority of people would manage expectantly at this stage. So we move on to the next slide. Next slide. So 3 days later, after testing positive, the patient becomes symptomatic. And she develops a cough, some myalgia, a sore throat, some coryzal symptoms, and a headache. She has a SATS probe at home, and saturations on room air were 99% with no dyspnea. Her fevers are relatively well controlled with paracetamol. So at this point, next slide, we have audience participation question number 2. And we should launch the poll to see if the majority of people have changed the management at this stage. And let's see if we can see the results at this stage. So a slight change. Previously, almost 2/3 of people advocated expectant management, and now almost 30% advocating antiviral treatment, and a selection of other treatments are recommended as well. Next slide. So I'll hand over to Professor Warnatz.
Thank you, Adrian. So the question we were asking each other at this time, I don't see the presentation anymore, was, should we intervene early in patients with antibody deficiency with COVID-19? And if so, what are the reasons and when? And if so, with what? And we will continue this discussion later. And I would just like to share 3 cases we were able to collect experience with in Freiburg. Here is case number 1. This is a 71-year-old male whom we saw very briefly, and you can see here the dates when he turned positive, tested positive, but he was asymptomatic at the time. However, knowing that he was common variant immunodeficiency and he had risk factors for severe course of COVID, we discussed with the infectious disease specialists about early intervention. And at that time, we were able to get hold of remdesivir. So we put him on remdesivir. And you see here the CT values of the swab of the throat of this patient. And you do see that the CT value increased during this remdesivir therapy. However, after stopping remdesivir, you can see that the CT value decreased again. And at this point, we made the decision to give him convalescent plasma. Usually we would give him this on 2 consecutive days. However, he had a fever reaction to the first one, which succumbed on the next day immediately, and he felt well. So that we gave him the second dose, and he turned negative and was released from the hospital. The second patient is a patient, young patient, 30-year-old female, whom we knew that she had an NF-kappa B2 deficiency. Now, from very few data existing at that time, there was a hint that NF-kappa B2 deficiency might have a more severe course, especially due to the publication with Isabel Mates and Yaki, where the 2 young NF-kappa B patients both ended up on intensive care. We had an internal discussion, and since she had presented with fever, cough, and later onset of dyspnea, as well as a CRP value of over 200, we decided to give her intensified therapy with clear evidence in the imaging for SARS-CoV-2 positive pneumonia. And she was treated, as you can see here, with remdesivir, a prolonged period, dexamethasone due to the highly inflammatory situation in her. She got prophylactic antibiotic, and we decided to also start at the same time convalescent plasma. She fortunately responded very quickly clinically. She had no symptoms the day after the convalescent plasma therapy, while the other therapies were still continued. And you can see at the right lower bottom of the thing, the increase of the CT values, and she turned negative and was released home. The third patient is a patient we are seeing for a long period already, who is a 61-year-old CVID patient with pre-existing comorbidities, with a renal insufficiency stage 3, arterial hypertension, and as part of the CVID phenotype, he had splenomegaly, autoimmune cytopenia, and some but not severe lung involvement. He presented symptomatic, was tested positive, and due to the comorbidities, we decided at this time to intervene due to fever and dyspnea with convalescent plasma, and purposely left out remdesivir. You can see here the response to the convalescent plasma, where he clearly increased rapidly with the CT values into the almost negative range, way above 30. However, during the coming weeks, you could see the slow but clear decline of the CT values, so that you decided later on to re-intervene with the second one, and he finally turned after many days, and we'll come back to that, negative. So with this impressions of these three cases, I'm looking forward to the discussion at the end. I just would like to thank at this point Julia Langmeli, who put together these data for me, and I hand back over to Adrian. Thank you.
So we now reach day 14 of her illness, and the patient remains pyrexial. She has a fever which is no longer well controlled with paracetamol, between 38 and 39 degrees Celsius, and she desaturates to 88% on room air when climbing stairs, although her saturations are at 95% while she's at rest. She continues to have a cough, a fever, and myalgia, and at this point she's brought to accident and emergency, where her blood tests are shown below. And notably, she has some inflammatory markers. The CRP is up. Her D-dimer is negative to look for thromboembolism, and the PCR for COVID remains positive. Next slide. This is her chest X-ray at the time, showing bilateral interstitial infiltrates consistent with COVID. Next slide. Next slide. So the question at this point is, do we intervene at this stage? And I think there should be another poll that should be launched very shortly. Should we see the results of that polling? So very few individuals are advocating expectant management at this stage, and then a sort of split between convalescent plasma remdesivir with a slight majority favouring dexamethasone at this point in time. Should we move on to the next slide? So I'll show some data from the UK PIN COVID registry pertaining to the outcomes from CVID patients. We collected data nationwide. We had 21 centres across the UK submitting data, and currently we have 183 documented cases of COVID in primary and secondary immunodeficiency across the UK. We included both suspected cases early in the pandemic where PCR was not available, and proven cases by PCR as well. Next slide. Within that registry, there are 58 patients with CVID, including 2 patients with NF-kappa B1 haploinsufficiency and 1 with CTLA-4 haploinsufficiency, although the vast majority are genetically undefined. The mean age was 49 years, and the vast majority of patients were on immunoglobulin replacement. Over half the cohort were hospitalised, and the overall mortality within the cohort was 19%. Next slide. So what factors influence hospitalisation in this cohort? Well, certainly age was the major risk factor, with individuals who were older being hospitalised more frequently, but also the baseline lymphocyte count taken pre-COVID at their last immunology appointment was also predictive. Next slide. And then what factors, other factors influence hospitalization? Well, the presence of chronic lung disease and cardiovascular disease also significantly influence the risk of hospitalization in this cohort. Next slide. We went on to look at what factors influence mortality within CVID patients. And again, we saw a similar pattern, with increasing age being the major risk factor. Lymphocyte count didn't affect mortality significantly, and it's worth remembering that the mean age of the general UK population who died during the COVID pandemic was 83 years old, whereas the median age within this cohort was 60 years old. So considerably younger individuals were succumbing to COVID if they had CVID. Next slide. What factors influence mortality? The only other factor that was identified in the analysis was the presence of chronic lung disease. All the other comorbidities didn't significantly influence mortality. Next slide. This is a comparison of CVID mortality with that of the UK general population, analysed in two ways. Firstly, through the infection fatality ratio in comparison with the CVID cohort on the left and the UK general population, and then the inpatient mortality data. So those are the patients who are unwell enough to come to hospital. The data there is sourced from the ICIRIC trial, which was a large UK trial, multi-centre across the UK, gathering information about the general population who were admitted to hospital with COVID. And as you can see, above the age of 40, there is considerably increased mortality at each age interval for the CVID population. Next slide. So the conclusions from this data are that CVID mortality, or mortality from COVID-19 in the CVID population, exceeds that of the general population and also occurs at an earlier age, and that there are risk factors that include increasing age, low lymphocyte count, and cardiovascular disease and chronic lung disease. They're risk factors for hospitalization, and increasing age and chronic lung disease are risk factors for mortality in the UK population. Next slide. So moving back to the case, and again, by the end of March 2021, our patient had had a short stay in hospital, 24 hours, and was discharged on amoxicillin. She hadn't received any specific treatment because she wasn't eligible for enrolment in the recovery trial, which was a large UK multi-site, multi-arm trial of various therapeutics for COVID-19. She had a slow symptomatic recovery over the next 4 weeks, but her fever and cough had settled by day 21. Profound myalgia and fatigue continued, and her saturations gradually improved to 97% on room air with no desaturations when she went up and down the stairs. She was, however, enrolled in an enhanced viral surveillance program and had weekly or twice weekly PCR tests, nasopharyngeal swabs. All of them, taken between March and April 2021, remained positive. She had some dried blood spot analysis for COVID antibodies, which was negative at day 35. Next slide. So a question at this point in time, shall we launch the poll? In this individual who's clinically improving but remains PCR positive, what management would you recommend? Okay, should we close the poll and see the results at this stage? So a significant shift back to expectant management at this stage with this clinically improving patient. Should we move on to the next slide? And I'll hand over to David Lowe.
Great, thanks very much, Adrian. So the question really at this point is about treating prolonged COVID in antibody deficient patients. Now there are, of course, two different clinical scenarios. I'll try and touch on them both, but one is perhaps Adrian's case where the patient is well, and another is where the patient is unwell, remains symptomatically unwell. And of course, there is also the phenomenon that we'll see where the patient looks like they're well and looks like they may have recovered, but then subsequently relapses. And if we can go to the next slide, I think this is, I've got just one case here. There are several I could have chosen, but this case I think illustrates the problem quite nicely. Now, this is a patient, a secondary antibody deficient patient who'd received prior anti-CD20 rituximab treatment for hematological malignancy, but wasn't actually on immunoglobulin replacement. And in fact, no one had really been monitoring her immunoglobulins. She comes in to hospital initially with what looked like and if you look at the left-hand side of the graph, what looks like a very mild case of COVID-19. And as you look along the bottom bars, green is negative and red is positive. So had a negative but then a positive nasopharyngeal swab for COVID with a relatively mild illness. The CRP is the dark blue bar, and you can see that, that's the C-reactive protein. That's not particularly elevated. And she ends up going home without any specific management instituted. But she comes back, and you can look at the time interval at the bottom. She comes back about 6 weeks, 7 weeks down the line. And this time she's much more unwell. And in fact, she ends up being admitted to intensive care. And you can see that a lot of samples along the bottom there are taken from endotracheal aspirate. So she is in hospital in intensive care with a severe case of COVID, and she's treated with remdesivir. And the remdesivir appears to be quite effective, and it brings down her C-reactive protein, as you can see, that dark blue bar, but her tests remain positive in the airways and in fact in blood throughout that course. But she then improves, and although she remains on intensive care, she's much better. But you can see along the bottom that then tests start to become positive again in her nasopharyngeal swab and in her blood. And eventually her CRP goes up significantly again, and we treat her with remdesivir again. We also got viral load data. It's not on here, but the viral load comes down very nicely. And actually what you can see is that the blood with the remdesivir turns from positive to negative. But we never get a negative in the endotracheal aspirate. And in fact, as you can see after that second course of remdesivir, she remains positive in the nasopharyngeal swab again. But again, remains reasonably well, and in fact gets discharged back to the ward. But then everything starts to deteriorate again. Her respiratory symptoms get worse, her oxygen levels fall, and she ends up with a third course of remdesivir. But on this occasion, we also managed to get on compassionate grounds the Regeneron monoclonal, Regencov-2, and you can see at that point, the CRP melts away completely. All of the tests in all compartments become negative, and she made a sustained recovery from that point and has never had a positive test since. She's now doing her gardening and very grateful. Next slide, please. So to try and capture the data on people with this either chronic course of COVID or a relapsing course of COVID, like the one I've just shown you, we conducted a survey across the UK, a relatively small survey, looking for patients with antibody deficiency who'd had either at least 21 days of clinical illness or at least 2 episodes of clinical illness, so at least 1 relapse. And we got 28 responses. Overall, the median duration of symptomatic disease was 49 days. And of course, you know, for the majority of people with COVID, it's 2 weeks or less. And the maximum recorded duration of symptomatic disease was 300 days. Next slide, please. This is the breakdown. And what's interesting, I mean, it's a relatively small sample size still. What's interesting is that XLA patients seem quite overrepresented. So 7 of the 28 cases had XLA. And secondary hypergammaglobulinemia with previous anti-CD20 treatment are the biggest group. So this seems to be the phenotype in which we're seeing now that they, of course, are a bigger group anyway in the population. But this does seem to be the patients where we're seeing this chronic or relapsing course of COVID. You can see that the majority were on immunoglobulin before they got COVID. That doesn't seem to protect them, as you might expect. Up to 4 clinical episodes of illness. And where we've got the data, a reasonable number of them became viremic with their illness as well. And the majority, of course, never had positive antibodies, which is, again, what we would anticipate. 2 who did have positive antibodies, we need to just interrogate that a little bit further, as it may be following the receipt of convalescent plasma. Next slide, please. So this is, there's a lot of data I could present from the survey, but I think this is probably the most important outcome. So these patients were all treated with different agents, some of them with nothing at all, some of them with just remdesivir, and within the people who were treated with remdesivir, the majority were treated with standard lengths of treatment up to 10 days, but a minority were treated with prolonged remdesivir. And then some were treated with antivirals, but also with either convalescent plasma or the Regeneron monoclonal. And you can see on the top graph here, the outcome according to treatment, so whether they cleared the virus or not. So it is possible with remdesivir alone to clear the virus, and possibly, especially if you give a prolonged course. These numbers are small, it's difficult to draw firm conclusions, but that's what it seems to be indicating at the moment. But certainly, if you give the combination therapy, that seems to be very effective. Now, some have a delayed clearance, and we've got one there on that top bar, and there's one patient who died actually, despite maximal therapy, died at about day 28, despite receiving all therapy. And that's the red bar at the top there of the people who received the combination therapy. If you look at the bottom graph, this is the same data essentially, but broken down per episode of illness. So among these 28 patients, there were 54 episodes of illness. And here we've classified them according to whether they cleared the virus, or whether they had delayed viral clearance, or whether they had a negative outcome, which was either a clinical relapse, persistent positivity, or death. And again, the same story really, that if you don't give any treatment, they don't seem to get better. If you give them standard courses of remdesivir, they might get better, but usually don't. Long course of remdesivir could have some benefit, but the combination therapy at the moment seems to be the most effective therapy. Next slide, please. That's it from me, and I'll hand back to Adrian.
Thank you. So by mid-April 2021, our patient had one further PCR positive, and she'd had no negative swabs returned. Clinically, she was back to normal, and she had received one dose of the AstraZeneca COVID vaccination. And she wants to return to work as a healthcare worker on the hemato-oncology day unit. Next slide. Should we launch the poll? There we go. So, can this persistently positive CVID patient safely return to work with extremely vulnerable patients in a healthcare setting? So, a real spread of results of how to advise this patient on returning to work, and we'll discuss that in the discussion at the end. Next slide. So just a brief thank you to all the immunology teams across the UK who have submitted cases to the UK PIN registry, and our study team who've helped with the analysis of that data. Thank you very much. And over to Professor Cunningham Rundles.
Thank you very much for that extremely interesting point of view. I mean, really, we have the same questions no matter where we are seeing our patients. So I will give you the quick capsule view from our situation in New York. As you can see from the 50 patients that have developed this COVID infection in our particular cohort, it seems every time we have looked at the data, we discover something which we didn't see before. But first of all, the big picture, of course, is that CVID is, somewhere around 56% of the patient group. And if you also look, you can see that we also had 2 NF-kappa-B2 in this cohort and 1 CTLA-4, a little bit as reported just a moment ago in this cohort. You would expect to see that. And we also had 1 who had a STAT3 mutation as well, quite symptomatic, also with previous rather severe lung disease. So on the slide, looking around the further pie, so to speak, then you can see then we have a rather disproportionate in a way. Again, XLA is not 10% of our patient population, certainly, but 10% of this group. And then a few that you would better describe probably as IgG deficient or hyper-IgM syndrome, IgA, IgG2 subclass deficient. And by the time we get around as far as that, then you can see these are the antibody deficient patients. In terms of age, just a quick point about that is that for the XLA, there was one who was 10 years old, and all of the others that I'm talking about here are adult, with one exception, and that's an infant who turned out to have a interferon receptor gamma 2 mutation, which brought him in with COVID, strangely enough, which he managed extremely well. On the other hand, in looking at his x-rays, there were some lesions in the spleen, which deserved further attention, which were then biopsied, which showed MAI. So this is one of those strange situations where the patient comes in with one diagnosis and leaves with an additional one or something quite different. Notice too, just with a tiny bit of regard to what was mentioned a moment ago about the slight excess of those with no B cells, I don't have anyone here on this particular slide. I think maybe there's one who had previous rituximab, but as you can see, we had one previously with Good syndrome, who with no B cells, of course, would perhaps be expected not to produce immunoglobulin either. So that's just our bigger picture. One more tiny note would be the patient with a STAT3 mutation was one who was sick over the weekend with a little bit of fever and was persistently positive for a period of somewhere around 6 weeks, PCR positive, but was never sick, and only discovered himself to be PCR positive because he thought he should be tested and was exposed to those with this particular COVID infection. So that was another kind of curious thing, is that STAT3 might be somewhat protective, actually, as that particular patient might have pointed out to us. One other point to mention is that 2 people on this slide, or possibly it's 3 now, have actually contracted COVID twice. In other words, you might say, well, how do you know they weren't positive in the interval? Because, for example, March to September is a long time to have negatives and then all of a sudden pop up again positive. And so these are people who live in a community where not necessarily precautions were being taken incredibly seriously. So 2 of our patients who are quite antibody deficient managed to catch the same virus again, which I think is pretty unusual. And I don't know how often others have seen that, but I'd love to know the answer to that as well. Could I have the next slide? So just the numbers, because we're all wondering who did get into the hospital and who did not. So of the 50 patients, 32 of them were never admitted. 10 of them were put into a hospital ward where they received only standard nasal cannula oxygen. And then another 3 were put into the hospital but did not really need oxygen support. And then 5 required mechanical ventilation, of which 4 actually died. In terms of treatment, we've given convalescent plasma to 11 of these patients. And I think that Klaus Warnatz is going to talk about that, because we collaborated with Klaus to put the data together with the international collaboration that he's put together. So you'll hear, I think, a little bit more about that. We've also had access to monoclonal antibodies. This is done only on an outpatient basis in the United States. And so these patients were not admitted but got monoclonal antibodies elsewhere or at Mount Sinai. And then 5 of the patients as well got remdesivir. In terms of outcomes, 46 survived and 4, as I mentioned a moment ago, did not survive. The 4 that did not survive are actually included in the large cohort of patients published by Isabel Metz from the IUIS. And so if there's more details about those, that would be in that particular manuscript. They were all in the older category and had, as you probably must have gathered, they also had additional medical morbidities, for example, diabetes, hypertension. One had previously had a kidney transplant, had been treated also for lymphoma. And so those patients really had extra reasons, perhaps, for such a poor outcome. The next slide, please. Just to quickly indicate those who got the convalescent plasma, for me, I was very eager to give it to those who had X-linked agammaglobulinemia in particular, or those who were doing exceptionally poorly, because, of course, we had no other therapies in the early moments aside from the convalescent plasma. That doesn't mean that's the only thing they got, so I'm just simply making a slide to show the spread here. The one with hyper IgE syndrome had also quite a bit of lung disease, previously been treated for lymphoma. And of course, we were quite anxious about his particular situation. The next slide, because I think this will be included in Klaus's reports. I think every one of us have seen things and learned things that we had no way of knowing previously. And I certainly did not know this. This is a young man of 21 years old, known hyper IgN syndrome, known mutation. He was admitted for worsening oral ulcers in the middle of the summer. He really couldn't eat. He lost 20 pounds at least, and then he was treated with Valtrex. We actually biopsied the back of the palate, thinking that it had to be herpetic or CMV or some other, opportunistic infection in this young man. He had never had anything of this sort before. And of course, we gave him all the usual treatment. He had a little bit of fever at one time. He had some chills, productive cough, but no shortness of breath. And frankly, on the x-rays, he had no pneumonia. But we were very concerned about him. And on the biopsies, as I say, the PCR did not show any herpes at all. And I'm not exactly even sure why we did this. Of course, we would have tested the PCR for COVID, and we did. But we also sent off a blood sample to our experimental laboratory, which was doing at the time COVID antibodies, IgG, IgA, and IgM. And curiously enough, he turned out to have a COVID serum IgM, which was positive. And by the way, continues to be positive at this point. So I didn't realize that the hyper IgMs would be making serum IgM, but now I think, of course, we realize that the IgM in a patient with hyper IgM is actually functional. This is not the end of the story with this young man. He actually got admitted back to the hospital a couple of weeks later and still has quite a bit of gastrointestinal disease. The biopsy of the palate, I don't have the immunofluorescence to show you that, was positive. And we are now looking into the lower gastrointestinal tract exactly for the same reason. One of my colleagues, Saurabh Mahendru, has a wonderful immunofluorescence method for detecting COVID in gastrointestinal tissues. And they, of course, will be publishing that, separately. They don't include our patients, but this is the intersection that we've had with the gastrointestinal service. So thank you very much. And I'm certain that we've all picked up so many things that we had no idea were possible beforehand. And one of those is that it doesn't always look the same. And I think this case sort of has taught us that really one more time. Thanks very much, Siobhan.
Great, thank you very much, Charlotte. And I could ask all the panelists to turn their cameras and microphones back on, and if we could go to a panel view, that'd be great. We do have a few questions in the Q&A, and I'm going to try and weave those into our discussion. So much to say and so little time, but thank you all for doing a great job with the slides. So I'm going to start off and just ask, I guess the first question is, should we, of the panel members who are here, how many of you feel that we should intervene early in COVID? And if so, at what stage? Should we be intervening in our antibody deficient patients as soon as they're PCR positive? Should we wait till they become symptomatic or wait for something else? So Charlotte, I'm going to ask for your opinion first.
Well, that's a tough one. One of my XLA patients did not want to come to the hospital. He's 40 years old. And he really didn't want to. He was okay at home. His oxygen was decent. But when we finally got him to come into the hospital and take a CT of his chest, I'm thinking, oh gosh, we can't possibly be wanting this chronic lung disease to set in. And what does COVID do to the lung in the long run? I think that's my question. And so to me, I pretty much forced his hand, made him come into the hospital, gave him plasma, and within about 48 hours, he's out of the hospital, back home again, and his chest is fine. But I don't like the idea of chest damage. And so to me, I'm getting to be the situation of wanting to intervene somewhat earlier. And I think some of my patients looking back, I wish I had intervened somewhat earlier and did not allow them to be at home for a while.
Mm-hmm. Klaus, what's your view? Do you intervene at PCR, at symptoms? What's your thought?
Right. So I think, I think the ultimate outcome is how we can help our patients. So I think that is what really concerns us. But there is obviously a financial concern, also whether you can get a hold of the treatment. So I think having seen our total cohort, and I think we have right now 35 patients with CVID and who had attracted COVID over the time, I would say there are many of them who came through fine. Within a week, they cleared the virus and seemed to be fine. So for me, I think probably it is an evaluation of the risk factors I see in these patients, which we heard age is the major one, lung damage is the second one. I think certain, we heard about the anti-interferon antibodies. We heard here about that certain monogenic defects may be higher risk. And I have mentioned NF-kappa B2, which was the incentive for this one young lady who didn't have any other risk factors, but we were just worried about her at that time and decided to treat. And plus, she had a highly inflammatory response. So I would say that in the evaluation within the first week of seeing how the patient is doing, of how old the patient is, seeing what the inflammatory response does, and also seeing where the CT values are. I think that is probably also a clue, because not all patients have immediately very high CT values. And I think there I would be probably also allow myself to wait a bit longer. But I think these are all factors which come in there. And then obviously the patient decision, him or herself, as Charlotte said. I mean, if the patient says, no, thank you. And we had patients where I thought, no, you need to come in. And she said, no, I'm waiting longer and I'm waiting longer. And she's negative now. So, and I don't know the long-term outcome, I agree, but the short-term outcome was right. She was right to stay home. So I think it is a critical evaluation of the factors, but I do think there are patients where I would still definitely consider to intervene early. Yes. And I would probably to precipitate also the next question maybe is what type of treatment, or maybe we leave first the round and then come back to what type of treatment. Sorry. Yeah.
David, do you have a different view? Would you intervene early? Have you got a different view on that?
Well, I think actually it's hard to answer without that bit that Klaus just raised at the end about what are you going to use. And because I absolutely take the point that if you're going to bring people in for 10 days of remdesivir and convalescent plasma or monoclonals, then that's a big ask for the patient, actually. And we all know that, yes, they might get better by themselves. And clearly we've all had cases where that's happened. I think if we had orally active antivirals, for example, or if the monoclonals, which you can give as a single shot, are effective on their own, then I think that might change the balance slightly. I mean, I completely take the point that just waiting to see what trajectory they're heading on is reasonable, perhaps, but I think we almost need to set what the threshold is. How long do you allow them to be positive for? Because of course, even an immunocompetent person, they might be positive for 4 weeks, 6 weeks, but then you start to get into the realms of what Charlotte's concerns, that if you just leave these patients untreated, what's happening to their lungs? Absolutely agree with that. What do we do with them in terms of infection control in the community and in the hospital? They've constantly got a risk that they're going to relapse and they're going to actually get severe clinical illness and end up in hospital or intensive care. So actually, I mean, on balance, if we had a treatment that was easy to administer on an outpatient basis, then actually, I mean, my pendulum has swung quite a lot towards early intervention, because I think the treatments are well tolerated. So it's not like we're giving them chemo, and you know they're well tolerated, and so the risk of doing nothing might actually be substantial. In some of them, they'll be fine, but the risk of doing nothing could be quite high for these patients. So I think I would err towards early treatment, but it does depend on what agents we're going to choose there.
Okay, and just a final question on that. Do you feel different, given what we've heard about XLA so far, for the three of you, do you feel differently about XLA? Would you intervene earlier in an XLA patient than a patient with a different form of antibody deficiency? You can give a yes, no.
I'm going to have to go yes there.
Yeah, I'd go yes as well. We've seen a lot of young XLAs have a pretty stormy course with lots of relapses.
Yeah.
Okay, thank you. Let's move on to the issue about what to do then once patients have prolonged COVID and chronic COVID.
Can I just, because I mean, I think as we said before, I mean, I think the really critical point is, so what are we giving them? If we decide we treat, what are we giving them? And I think the options right now are obviously remdesivir. The other option is convalescent plasma, and the third option is monoclonals. And I think this is the spectrum of interventions where we have the feeling that they do something. And to be honest, I would lean very strongly, if monoclonals are available and you can treat them, I would strongly lean towards monoclonal in this population. And I think here again, I think a very important point is that unlike all the studies showing that monoclonals or convalescent plasma works only in a very short time frame, this is not true in my hands, at least for our patients. The time frame is longer, and so even if we are beyond day 7, I think it's still worth considering these treatments, and they still will work in most of them. And actually, as Charlotte said, that we're trying to gather these for convalescent plasma right now, it worked in all of them. I mean, and these were treated days way later than what the normal population would be considered for being treated that way. So I think that is a very, very important point to consider. I think the remdesivir, and I think I thank you for both examples you gave. I think we do see effect of remdesivir. We had a patient who came in and was treated remdesivir, but we did have at least 2 remdesivir treated patients who profited by viral load, but then relapsed as soon as you stop the drug. And so I think from my point for this population, if the access is there for monoclonal antibodies or convalescent plasma, I would probably prefer either of these treatments.
And a question from the chat is, do you have a preference for monoclonal over convalescent if it's available?
I think this is a fantastic question. I think standardized treatment would be probably more readily with the monoclonals, obviously, and I think that would maybe do away with a lot of the quality control for the convalescent plasma. However, there might be situations like anti-interferon antibodies. Maybe they may profit more from the convalescent plasma. I have no clue, But I mean, you obviously add not only the antibodies, but you add a lot of stuff, and probably interferon as well. So I don't know, but I think in general, if Regeneron, and I think it's important, but it became clear that one single monoclonal will not do the job. I think it has to be a combination, especially now in a time where we have more and more to do with viral resistance in these patients, and not in these patients, but in general in the population. Sorry. Mm-hmm.
Okay, and another question from the chat is, should pharma perform studies using monoclonals in immunocompromised patients, and are there any initiatives that we know of? Anybody got a feeling about that? David, let's go to you, because I know you've been working hard on this.
Yeah, so there are clearly trials of the monoclonals continuing, and in fact there's a trial of convalescent plasma in immunodeficient patients as well, should be getting going, I think relatively soon. But there aren't, as far as I'm aware, trials specifically to answer the questions that we've got here. So trials to look at early intervention, and I accept with what Klaus was saying. I mean, it doesn't have to be as early as an immunocompetent person. It just has to be up front, while they're still relatively unwell. But if they've been unwell for 2 weeks, I have no doubt it will still work. I mean, in our patients, it still works after several months. The antibody-based therapies, because they're not mounting their own antibodies, of course. So yeah, I think the difficulty in terms of a study is saying what you would randomize to, and really, I mean, if we were, rather than just an observational study, which has got merits, but I think it might be delayed versus early treatment. I mean, that might be the way to go. The other thing that, and again, just to pick up on something Klaus said, is that I think we do need to establish whether the convalescent plasma or the monoclonals by themselves are sufficient treatment, and especially in that early phase when the viral load is very high. Because, we intuitively also use the antivirals because we wanted to get the viral load down and then use the monoclonals. That may not be required, but it just, in terms of things like viral resistance, driving viral resistance, it just felt like it was a safer thing to do. Because, I mean, remdesivir, it clearly gets the viral load down and may get them symptomatically better. It just might not clear the virus, or they might relapse. But the combination felt like the right thing to do, but we've got no evidence for that at all. So,
I think David, I think that's a very important question. So actually, for that purpose, we treated several ones just with convalescent plasma. So we didn't give them remdesivir, and worked fine. So I think, these are only single cases. So I think we're far from evidence here. But I do think that it does work in many. And we had the one patient I showed where actually the convalescent plasma was given. We couldn't give him remdesivir because his renal function was very poor. And so we just gave him convalescent plasma, and he actually relapsed after convalescent plasma. And here become the next issue, which is obviously development of resistance, immunoescape variants. And he was the only one in our cohort who actually developed an immune escape variant, but fortunately responded to the second treatment, which was given. And I think what I would suggest from that, learning from that, and this is again just gut feeling, and there's no evidence, but I probably would really screen very closely the CT values of the swabs. And if I see that he really goes back and down with the CT value, I would immediately give the second one rather than we waited for over a month because we weren't quite sure whether we can give it again and we weren't still debating. But I think this time I would probably give it earlier to give the virus as little chance as possible to accumulate variants during this time. Mm-hmm.
Yeah, I mean, you probably have seen there was a case from the UK that I think has been published now, which showed exactly that sort of viral escape with serial convalescent plasma. So that has made people nervous, and it's made the regulators and powers that be nervous, certainly in the UK. But I think it's an important thing to establish. And I agree. I think they may well work by themselves, and that's much easier to administer early as well, and without having to admit someone for an intravenous treatment for 10 days.
Right.
Okay, and also from the chat, if you are giving plasma or monoclonal antibodies, does it alter when or the dosing that you give for immunoglobulin replacement therapy, or do you just ignore that? Charlotte, you look like you're going to say something.
I ignore it.
You ignore it. Okay, everybody agrees with that. Okay, I'm conscious of the time, but I'm also conscious that we're really kind of getting to the meat now. If the option for the webinar is to run over a bit like a session in a real meeting, a real live meeting with a bad chair. So if I'm very sorry for those of you who really do have to leave, but I think if the panelists are all happy, we should just try and continue the discussion. And for those who do have to leave, we will be posting the webinar, hopefully on the ESID website, so you can catch up at the end of the discussion. Right. So on to the issue. Are we happy? We've answered. I think I'm fair to say that we've agreed that we have a preference for intervening early, but there is an option to see how patients initially start to present. Sure. We probably feel more comfortable about intervening early in XLA. There is a question in the chat about whether that also includes XLA children. Has anybody got an experience?
My answer is yes. You cannot really afford that lung damage.
Okay, so there is. The point in the chat was that somebody's had a couple. Scott Hackett from the UK has had a couple of children who have resolved fairly quickly.
I mean, it comes back to the point I made before. Some people clearly will, but this is a balance of risks. It's a balance. The risk of doing something is actually relatively low with these drugs, and the risk of doing nothing could actually be quite high. It may not be. They may do fine. But actually, leaving them with that sort of chronic relapsing COVID, I think is, from many aspects, is a negative outcome for the patient.
I think what will be Oh, sorry. Go ahead, Charlotte.
No, I was just thinking. You remember there was an early bunch of cases. One of them was Isabella Quinty, was discussing the XLA, and perhaps they were getting a benefit, perhaps because they have no BTK and monocytes, macrophages, dendritic cells, that they would never have all the inflammatory complications. And I'm thinking, well, I understand that, but then we went ahead and admitted 5 of ours. So, it's kind of a two-way street, Yeah. Probably some of them might be able to clear it at home, but we don't know that. And it's the same story. You're going to have to look at your individual patient.
Yeah, and I guess a word of caution about clearance is what test do you do to decide clearance? Because we've recently had an adult with XLA who was positive last year, who has seemed to be extremely well, persistently NPA positive, but has had CT changes in November last year, having been positive in the summer, and persistent changes 3 months later, multiple NPAs, all negative, and we've just recently acquired a sputum COVID sample, which is positive. So, of course, we could say, did he get and clear and he's got again, this is a second COVID, or actually have we been sitting on a chronic COVID without any inflammatory features, but definitely with interstitial change on CT scanning?
Well,
and we have other CVID patients with exactly that, with a negative NPA, but consistently positive sputum.
Yeah.
So I think that, and that is something that we always say to people, is that you can't really confirm that they've cleared until you've got a lower respiratory tract sample, or you're completely sure that there's actually nothing going on in the lungs on imaging.
Important. Can I just, I think from the question, whom to treat early, I think for me, it would be really a follow-up during this first week. I think we will have, unless there's a dramatic course of disease, that is different. But we're talking here about patients who have mild disease, maximum moderate disease, right? But probably mild, even moderate. Most of us probably feel like we should do something. But mild disease, we're talking about asymptomatic and mild disease. And I would say, I would not treat them within the first week. I would really use that time to follow up, see what the CT value does, what does the inflammatory response show. And if that during the first week shows clearly that the CT values rise, that the patient remains asymptomatic, shows no inflammatory response, I would be happy to wait, even if it has XLA or whatever. I think I would be more leaning towards that. And I think what we really need to do is we really need to reanalyze all our cohort patients. What are the risk factors, actually, which we can see early to really say that this patient is at the risk of developing a severe disease, to be prepared next time better, to really tell the patient, yes, you have this and this and this, and we know that these are risk factors beside age, which will probably lean towards that. And I think then we can more confidently probably make that suggestion, I think.
Sounds like we all need to be collecting early markers for our patients, and we maybe ought to agree what those markers are. That's for another day's discussion, but that would be helpful for putting the data together ultimately.
Can I just ask, Klaus, how long then would you leave them? Would there be, if they remain reasonably well, is there a threshold? Because of course a lot of the patients are never completely well from a respiratory perspective anyway. So is there a threshold at which you would treat if they remain positive for 6 weeks, 8 weeks? We have some of these difficult ones as well.
I know, totally. So there was just today, the Iranian society remembered the death of Ashgar Agomahadi today. And so Kate Sullivan gave a talk on corona. And so I thought, that's perfect. I can ask her all these questions, which I don't know the answers to. And when I wrote her, so how long would you leave them, question mark, weeks, before you then decide anyway to treat? And she said, oh, I don't have so many. So she didn't come back with an answer on this one. I think for myself personally, this is a discussion with the patient. The question how he can be isolated at home, whether he has a lot of problems, self-isolating himself. And I think all these things will play a role there. How much is the risk of that he infects someone else who is probably a danger too of having a severe disease? All these things. So if I would say, then I would probably have that patient, a severe discussion with that patient in the second week. Say, look, you're now more than 10 days positive, let's say. And now we need to make a criteria where we say, no, we would treat and we wouldn't treat. And I would probably, anyone who is more than 2 weeks positive, I would try to offer them, if I have access to treatment, would try to offer them a treatment unless I clearly see that the CT value goes up 30, 32, then I would probably wait until he's negative. And, as Charlotte said, some of our patients said, no, I'm fine, I'm not coming, bye-bye. And then after 5-6 weeks, they finally got their negative result. But I had patients where the husband was so frustrated that he had to stay home all the time because he had to be in co-isolation with a positive wife. So I think there are a lot of personal stories behind that, which I think is beyond the discussion we can do now.
Yeah. But presumably, if there are X-ray changes, then that would change your view.
Yeah.
Okay. Are any of you using or advocating monoclonal as prophylaxis? That's a question from the.
We're launching a study of exactly that in New York, because I think that's the way to go. Until it shows up in the gamma globulin solutions, we have no better answers, do we?
Okay.
We have a plan for that.
So we're going to get some data, hopefully.
It sounds like a great solution. As you say, hopefully, yes, we'll get enough through into the immunoglobulin supplies from vaccinated individuals. That should come over time. But given the delay from harvest to the patient receiving it, that could still be a while. So I think that could be a fantastic use of these products in these patients. But then it comes down to cost, etc., which is not insignificant.
There are a few questions in the chat about duration of coverage, if you give, or duration of the persistence of the monoclonal or convalescent serum. Does anybody have any feeling about that? If you start to give this as prophylaxis, how often would it have to be?
Once a month.
Okay.
Yeah, so we have some data on viral neutralization, which persists up to about, and we certainly have it up to about 8 weeks, which that was after the Regeneron. Mm-hmm. It was quite impressive, actually, how long it lasted. And it was maximal neutralization, and you could dilute the serum down quite significantly and still neutralize the virus in a pseudo neutralization assay at least.
I heard that too. And I think that's why I think only the monoclonals will be an option in there. Convalescent plasma, we treated our patients. We could not detect antibody after already a week. We didn't see the antibodies anymore. So I think that is too low. So I think, yes, I think if we want to do prophylaxis, it probably will have to be monoclonal just for the application. Yeah.
The compassionate release protocol in the United States is once a month. They've already sort of settled that.
I'm very jealous of Charlotte because she seems to have easy access to monoclonals, and we're just completely struggling.
Well, I don't know how easy it's going to be. It's the usual thing. It's a clinical trial, so it has to go through the clinical trials and the IRB and consent and all that business. But it's completely logical.
Mm-hmm. Okay, I'm conscious of time, so let's move on to the issue about chronic COVID, because we had quite a lot of discussion about that today. For the panelist members, would you treat somebody with persistently positive COVID, yes, no, or in what circumstances, and what would you use? So, David, let's start with you.
If they're symptomatic, have CT or chest X-ray changes, definitely. And I would use, at the moment, without any evidence of anything better, I would probably use still an antiviral plus something antibody-based, so remdesivir plus convalescent plasma or Regeneron, or any of the monoclonals, to be honest, but Regeneron's the one we've got experience with. And I agree with that earlier point that you'd probably want at least 2 drugs. So
how long would you wait to start treatment?
2 monoclonals. So how long would I wait? Well, again, as I say, if they're symptomatic, have lung changes, I wouldn't wait at all. Then it comes back to the question I tried to bounce to Klaus, which how long would you treat them if they're well? And if they're well but persistently positive, and that is, that's incredibly difficult. It starts to make me nervous once they're positive for more than about 6 to 8 weeks. As we said, the infection control issues, nobody can really completely cocoon themselves from the rest of the world. They might be, we in fact have evidence on this, there will be evolving novel variants, with you doing nothing, we're just leaving the virus untreated. So as much as we have concern about the treatments driving mutation, just that doing nothing does it. We know that from norovirus and things anyway. So I would probably, once you get to that point, even if they're well, I'd be trying to encourage them to have some treatment.
Klaus, what would you say?
If they go chronic, I would treat. I think because we have seen they all responded, and it just made life so much easier for them. And I think from our experience, I would really go for the antibodies. And I think we don't have access to Regeneron that easily, so it will be convalescent plasma for this time being. But I do think probably Regeneron makes things easier in the future. Again, immunoescape variants under this treatment need to be watched out for, and therefore you need to follow up on these patients, how well they responded and whether they really cleared the virus. And I learned now I have to do sputum as well to make sure that they really clear. But I think that's an important follow-up on these. Otherwise, you really create high immune pressure in a patient who cannot control that better either.
Mm-hmm. And you're happy to go without antivirals?
I think from our experience, I would do that, but also for collecting more experience on that, to be able to answer afterwards. Because, it is 10 days or at least 5 days remdesivir. It's a minimum you have to do. And that has to be IV, so it has to be inpatient. And so I think, the other options are shorter and more practical, I think.
Okay. Can I ask you just one other thing then? How long do you think you have, if you give monoclonals, how long do you think you have to wait until the patient clears? Or how long would you counsel a patient they're likely to have to wait until they clear?
So, that's it. Go ahead, Klaus.
Sorry, but I think you probably have, I don't have much experience with the monoclonals, but with the convalescent plasma, actually clearance was, in some of the patients, very fast. So that was actually within a week, they were negative. And as I said, like except one, they all remained negative. There were 2, I think, who had a prolonged period of where it took longer. And in one of them, we don't know when she was ever negative, because for some reason she circumvented all negative testing and got out because she had two tests where the CT value was above 33. So I think that was regarded as negative, and she got around with ever. So I don't think we ever had a negative test result from her. But so I think, yeah, so I would expect most of them clear it within a week. But there may be exceptions. And again, I think the follow-up is important to see how they respond. And if they don't clear, please follow up and to see whether the CT value starts falling again, showing that there's increasing viral replication again.
Okay. Charlotte, what would you do?
I'm really kind of stumped, because if you have somebody who's home and still viral positive, but they're feeling pretty well, I can't do anything about it. I can't give them monoclonal antibody, they don't qualify. I can't give them plasma because they don't qualify and I can't admit them. And I can't give them remdesivir because I can't admit them. So they have to stay home until they're negative. That would be the only thing I could suggest. I don't have another option.
I think we were all speaking. Sorry, so I think we're all speaking in an ideal world rather than under the sort of regulatory restrictions in our various countries. Because I think in reality, we're the same.
That makes me feel better.
In an ideal world, what would you do?
Oh, ideally, what I would do is I would bring them in and give them 4 shots of the best monoclonal and call it a day and say goodbye, go home and let's check you in a while. Sure.
There's a definite theme coming out here. We might not have done a trial, but there's certainly a kind of signature of experience coming through about antibody therapies.
Yeah.
Can I just add one point? So to add to what Klaus was saying, our experience generally with the monoclonals has been very rapid clearance as well. So there's been one patient, and interestingly, again, what it sort of encouraged us to think that the combined antiviral and antibody-based therapy was the way to go. That one patient who received them, so 3 weeks apart, they took much longer to clear, whereas most other people who received them together seem to clear very quickly. But again, we're still talking about small numbers and relatively anecdotal data. So I think we do need to work on that. The other thing, just to bear in mind, is that some of the oral antivirals, although they haven't necessarily been shown to have significant clinical effects in immunocompetent people, they do seem to at least get the viral load down. So there are data now for nitazoxanide, favipiravir, molnupiravir, the very early release from Merck, suggests that it at least reduces infectious virus quite rapidly. So, I think, we'll see what the trial data shows, but these agents might be useful to at least, get a bit of viral suppression and allow the monoclonals, for example, to really be effective. But that's another, that would need to be a study, of course.
Okay, so I'm going to ask you all for a brief answer on I'll ask David for an answer on something that's come up in several of the chat questions, and that's about mutations. How worried are we about mutations? Are we going to drive mutations without treatments? Are we going to drive mutations by not treating? What's the risk balance, do you think? And what should we be doing about this?
So my concern, my quite simple theory is that if you can get rid of the virus, it doesn't mutate anymore. So that's why I was sort of erring much more towards treating. Treating, yes, with the caveats about maybe leave it a couple of weeks if they're really well, but treating early if you can, because that's one of the negative consequences that you can avoid, because we know that, as I say, just in the absence of anything, you will get viral evolution. And we've got data, and other people have got data to show that. So I'm in fact more concerned by just doing nothing and allowing them to A, evolve novel variants, and B, potentially infect other people because they're sort of stuck out of the hospital. I'm more concerned by that rather than the treatments, because so far our evidence, and I think that gels everyone else's, that if you get the right treatment into them, you can eliminate the virus. And if you eliminate the virus, it's gone. There is no more mutation.
Okay, do either of the other two want to disagree with that, or we move on to the last couple of questions in the interest of time?
I think it will be important to understand the type of mutations we see in untreated patients. although we have very few numbers, but the ones who were positive for more than 6 weeks have acquired mutations, but interestingly, none of them acquired immune escape variants. So the classically described at this time variants have not been accumulated in these patients. So I think there might be something for it, that these variants are really pushed by the immune system, and that's why they're really immune escape variants and not just variants which just randomly come up, even so they may at some point. You're absolutely right. But I think, so I wouldn't, I think it will be interesting. So I think what I'm saying is I suggest everyone who has long-time positive patients, please try to get viral sequences. I think it will be very informative to find out what is the nature of these variants if you don't produce antibodies against the virus. And I think it might be different from what we see in immunocompetent people. Mm-hmm.
I completely agree. I think that we're operating on the assumption that this is true, and I've even seen it in the New York Times as a possibility, but the data isn't there. And I know that Michel Nissensweig at Rockefeller has said he didn't think it was going to happen this way because the evolution would be only pushed by an immune competent situation. So I think it would be much more interesting to get the data than speculate about that.
Okay, good point. So final then. What do you advise to your patients with regards to infection control if they have very prolonged positive, PCR positive testing? Charlotte.
Stay home. Sorry.
Klaus.
Oh, I think the great thing is the masks have done a beautiful job during these last months. Our patients had as few other infections as really amazing.
You're right.
So I always smiled when I saw East Asian people coming with masks, but I think they seem to work somehow, I must confess. So the answer is no, unless there is really a clear hint that there is a structural lung damage or so where I'm really worried about. But actually at the moment, I do not change the prophylaxis I give them just because they're now COVID positive.
What I meant was infection control. I didn't mean antibiotic prophylaxis. I meant, do you tell them they have to stay at home, or do you say it's okay, you can be out
infecting others? Sorry. Sorry. I apologize.
Public health. Public health.
I wasn't allowed to vote on the nurse, but I would have told the nurse to stay home, to be honest.
David, what would you say?
Yeah, unfortunately, I think that's right. And the difficulty, of course, is when they have household members who also want to go out and about, and especially kids at school and that sort of thing. So, I mean, we've had some cases like this where we just have to try and get regular tests on the household members to ensure that they at least stay negative. And the person themselves has to, limit their contact.
Yeah, it's a bit of a nightmare.
Yeah.
Adrian, are there any questions in the chat you think we haven't addressed that we could, or groups of questions that could be easily addressed? Or do you think we've made a decent stab?
I think we've made a decent stab at the questions and answered the majority of them. There's a question about vaccination, which is probably quite a broad topic.
And in fact, there's going to be an entire session, an entire grand round after the summer on vaccination. So I guess in terms of vaccination, are all panel members advising their CVID or antibody deficient patients to get COVID vaccination?
Yes.
Yeah. Yes.
Okay. Are you advising them to get any of the available COVID vaccinations?
Yes.
If there isn't a contraindication because of age or whatever.
Exactly. Yes.
AstraZeneca, yeah. And one last thing about, I guess, just on the topic of vaccination, I guess we don't really know what the response to vaccination or the protection is going to be in our patient population. And we started a study in the UK recently to look specifically at this. And
it's highly variable. That's
And Charlotte, do you have patients who you know have got infection following vaccination?
Infection following vaccination, no.
So I don't mean infected by the vaccination. I mean, do you know that we've got failure of any protection, or is that data just not available?
Well, we have people who didn't respond at all. So I think that we end up having to, tell them that they're still vulnerable as they were last fall.
Yeah, but we're talking about not responding in terms of antibody responses.
No antibody, but of course, even the infectious disease doctors don't want anybody to measure antibody because they keep saying, well, I don't know what antibody is the amount that you should have.
Yeah.
And even if you have something, is it good stuff? Is it the good stuff?
Yep. And I guess the other thing we don't know is whether cellular responses provide any
And then the cellular side is the whole, other side of the coin.
Yeah, and I think that will be really exciting. But I think for the time being, as somebody said already, it's important to advise the patients vaccination doesn't mean that you can now disregard the general rules for protection against infection. I think that is very, very important to make clear to all of our patients. Yeah.
So come back in September if you want to hear more about vaccination in this cohort. Come back next month if you want to know about interferon antibodies. I'm just going to ask the 3 panel members last question. Do you measure anti-interferon antibodies in any of your antibody deficient patients at the current time for the purpose of clinical management?
Not in the context of COVID.
We do it, but in terms of a study, we do collaborate with others.
Okay, so that's a research study.
Same with me, a collaboration, but I didn't even know the answer.
Okay, so next month, come back for COVID in patients with interferon pathway defects, which will include some discussion about the relevance of COVID vaccination, COVID anti-interferon antibodies in patients with COVID. And that is going to be a webinar on the 18th of May. I'm sorry we've overrun so much, so just see it like an in-person session with a bad chair. But it's been a great discussion. I'd really like to thank Adrian, who did the Lions work with regards to the slides, and the 3 panel members who have been wonderful and created some great discussion. Thanks for the audience. We've had a lot of participants today, over 130, which is great. I'm sorry if we didn't answer your questions. We'll see if we can get a download of the questions afterwards. And if we can, if there are things unanswered, we'll try and put that up on the Clinical Working Party web page of the ESID website. And please do fill in the feedback questionnaire. That's the only way we really know if we are meeting the needs of our PID community, and hopefully see you all next month. Thank you very much, everybody. Bye-bye.
Bye-bye.